Alrighty. Welcome everyone this evening. Thank you all for joining us for this month's social on pain science. My name is Tyler Axelson, and I serve on the nominating committee on the APTA Student Assembly Board of Directors, along with Zofia Heck and Tayo Akimboboyo. We have a wonderful group of panelists for you all this evening who are excited to answer all your questions. Before we get started, here are just a few house rules. Please keep your microphones muted at all times unless you are asking a question. To ask a question, you may either raise your hand or send them to me in the chat. But we want to keep this event as more interactive as possible. So please know that those people with their hands raised, they'll get called on first versus the chat. After the event, we'll go into smaller breakout rooms. There you can have a chance to ask further questions to our panelists, as well as network with other attendees. Real quick, before we get started, we're gonna do a group photo. So if everyone would like to turn on their cameras and smile, we're gonna take a nice group photo to get started. All right, we go. Doing 3, 2, and 1. Perfect. Thank you, everybody. All right, now on for our panelists. So we have 3 wonderful panelists on here who are all ready to share their expertise on pain science. First, we have Dr. Dominique Tull.
How you guys doing? Nice to meet you all. My background is through my training at Brooks Rehabilitation. I went to Florida A&M for PT school, and I trained in orthopedics to get my OCS as well as my fellowship at Brooks. And I'm just excited to be here. So excited to talk about pain with you guys.
Thank you, Dr. Tull. We're happy to have you here. Next, we have Dr. Brandy Parker.
Hi guys, I'm Brandy. I've worked in an outpatient orthopedic setting for 16 years. In the last few years, got more in the chronic pain area. So look forward to talking to you guys.
All right, thank you. And last but not least, we have Dr. Joe Tatta.
Hey everyone, it's great to be here with you this evening. I'm a physical therapist, of course, been a PT since 1997, worked in lots of different areas, but have focused most of the time in orthopedics and chronic pain management. And today I run my own company called the Integrative Pain Science Institute with a mission to help reverse and educate people on the importance of pain education and biopsychosocial skills to treat chronic pain.
Awesome, thank you. And Tyler just put in the chat, I don't know if anybody saw, just please introduce yourselves in the chat, let us know where you're from. All right, so let's get on. Let's get started with our questions. We'll start with Brandy. What drew you towards pain science?
One of the things that drew me in is not being able to treat a certain patient population. You know, from the moment I graduated, there's a certain population that came in the door that I could help, but never really fully capture their goals. So it was a missing tool that I didn't have in my toolbox. So what I've been able to work through has helped me treat a whole nother population.
Awesome, thank you. Dr. Tatta, what brought you into pain science?
You know, it's interesting. When I went back to school, so I initially, I'm a little bit older than probably most people here on the call. I initially had a bachelor's degree in physical therapy, and then later on went back to school for my doctorate in PT. But way back when there were bachelor's programs in physical therapy, we used to have a separate neuroanatomy class and a separate neurophysiology class. And I was really drawn to just kind of how the entire nervous system works, both the brain as well as the, peripheral and central nervous system. And then, as the research has grown in physical therapy and exercise science and psychology, it's all, really starting to point really toward pain science. So that's kind of just a quick overview of how I became interested in that.
That's fascinating. And Dr. Tull, what drew you towards pain science?
Yeah, for sure. So in my background in undergrad, I was a psychology major. So before PT, I majored in psychology. And then in my year after graduation, I actually worked in a psychiatric hospital. So I was deeply entrenched with a lot of individuals who had a lot of psychological problems, and just being able to see them and work with them up close as a patient care tech really just opened my mind to the empathy that's necessary to have a conversation with those people. So fast forward to me becoming a physical therapist, I before I really knew the process of like really what it is, before I knew what central sensitization was, or really the in-depth nature of what chronic pain was, I showed a lot of care for these patients. There were patients, you know, in my retrospect, looking back at it, who fell into those categories, but I just tried to be there for them. I tried to just be someone that was open, and that someone that they can talk to, and I found success. So then fast forward in residency, as I start to learn, oh crap, this is like something that it's an actual thing to be able to treat patients in this population. So since then, I've been deeply involved with it, and it's something I really love.
Yeah, thank you all for sharing. I always think it's interesting to hear how everyone got to where they're at. It's always interesting to see like the path views or the pathways we take to get to where we are in our career. So thank you all for sharing. So for our next question is, why do you think it's important for PT and PTA students to learn more about pain science? And Dr. Tatta, we'll start with you for this one.
It's a great question. It's important for physical therapists and physical therapy assistants to learn more about pain science, because currently the research shows that we actually have the most pain science or pain education in our curriculum, more than any other licensed health professional. And I'd love to see us continue to be able to, you know, kind of make that statement so the public knows that they can find safe and effective ways to treat chronic pain, and so we can interact in an interdisciplinary fashion with other health professionals. There's still a ton more to learn about pain, of course. I was working with a new DPT program about a year ago, and we, you know, put more and more pain science into the program. I think you're going to see, as the years go on, there's going to be entire classes dedicated to pain science. Some programs are going to probably weave it in every single course in some way. So it's important that, you know, we realize that this is obviously a major global problem. The burden of chronic pain causes not only physical but mental health disability. And both as PTs and PTAs, we can serve a really important role to help reverse that pain for people.
Awesome, thank you. Dr. Parker, how about you for the next?
I think Joe stated it very well, but in addition to that, I think pain science is a very growing and upcoming thing, and even what it means or what it is varies in opinions. But I've always felt since the day I graduated that we're a little bit of psychologists, and I've joked like we should dual build charge somehow, because there's so many components. You get an athlete that's 4 to 6 weeks, and you know they're shut down with activity, and they start getting depression and anxiety. Well, sometimes I wonder if now, fast forward 20, 30, 40 years, if some of those have become my chronic pain patients. So I do think the musculoskeletal exam is important, but ignoring the psychology component of pain, I think fails our patients, whether the short term or even the long term.
Yeah, that's a great point. It's amazing like how that could transfer from being an athlete to having chronic pain later on. It's fascinating. And Dr. Tull, why do you think it's important for PTs and PTA students to learn more about pain science?
You know, I think there's just such a heavy need for it, right? It's such a heavy need for us to have that in our toolbox, because these are people who kind of suffer in silence. You know, if any of us have interacted with individuals who may fall into the category of being a chronic pain patient or having central sensitization or nocioplastic pain, they've gone along in their medical journey through different practitioners who don't understand what's going on, who may tell them, you know, incorrect things, give them improper education, and just generally write them off. So most of the time when they come to us, they have so much distrust in the medical system because they've been told that they're crazy or that nothing's wrong. This X-ray, this imaging doesn't show anything, so you should be fine. So, and as Joe stated, I mean, we have so much knowledge in this arena within our curriculum, within the medical field. You know, as we continue to bolster that, we can really make an impact in these individuals' lives on a large scale.
Awesome, thank you guys. And as Tayo put in the group chat, please, any of the attendees out there, if you have a question for any of our panelists, please feel free to raise your hands or put them in the chat. We're really curious on what questions you guys have for our wonderful group of panelists this evening. So our next question is, can you share a story of how P&E and pain science has made a difference in your patients' lives? And Dr. Tull, if you'd like to start us off on this one.
Oh man, there's so many patients that I can draw from, but there's a very I'll say there's a very particular and a special example in my career. So there was a client that I worked with who actually dealt with multiple gunshot wounds. A younger guy, and he had a lot of physical impairments. He had drop foot. He had a very hypomobile knee. So there were a lot of things we had to work through orthopedically to kind of get him back together. But he was dealing with a lot of mental turmoil. So in the midst of our sessions, a lot of times we weren't able to exercise on some sessions. There were some sessions where literally all we did was talk and provided education so that he can have a better understanding of what was happening to his body when it comes to what he may be feeling that may not be that true nociceptive pain, but then also what's going on with his mind, right? What's going on with his mind, and how is he able to deal with the mental gymnastics of dealing with these physical impairments and how it's impacting him as a young 23-year-old guy. So something that I was able to really help him with, we got to a point to where I had to treat him pro bono. He didn't have appropriate insurance, so I had to care. So my lovely fiance, who's actually on this call, she's a marriage and family therapist. So we actually worked together with him to treat him physically and mentally, because something that I feel is extremely passionate about and feel that is important is that these individuals who have this type of pain, if we don't treat the mind first, we're not gonna be able to treat the body, right? So, and that may be through, if we're using strategies like PIPT, or most importantly, we can get them in the hands of a mental health professional. So that was an extremely impactful example of utilizing those pain science in my career.
Oh, that's an amazing story. Thank you for sharing that. Dr. Tatta, would you like to share a story next?
Sure. And I just want to make a distinction first, kind of before we move on, because some of the terms, we're throwing a lot of terms around. I think it's important for us as professionals to just clarify the terms, and that way our patients understand the terms. Pain science is the study of pain and nociception. So that's what you would learn in school as a PT or any other health professional. Pain education is a family of interventions that help people understand what's happening in their body, in their brain and their body with regard to pain. So just to kind of make those distinctions, because sometimes new therapists come out and they say, I'm going to use pain science, or I use pain science, and they put that on a website. And patients are very confused by that. So what you use pain education and psychological skills or coping skills to help people with pain. I had a patient, just to give you a quick example. I had a patient just recently who came to me with chronic lower back pain. Had chronic lower back pain for a very long time, has had every single imaging study, blood work, has seen probably about 10 different physicians, and couldn't find a reason. No one was really giving him a good reason for his pain. So we really went through his lifestyle and just looked at what his life, his workload, personal relationships, what all of that is really like for him. And it turned out that this man was under a lot of stress. There was recently a study published. There's a scientist that actually took apes, or chimpanzees actually, and injected them with the rabies virus and followed the different paths of the rabies virus in the nervous system to try to scope out all the different pathways in the human body. And they found this one particular pathway that links the adrenal glands to the part of the motor cortex that represents your lower back. And what they found through this study is that there's a direct link between stress and your lower back, let's say. So we have a direct neurophysiological link between stress and chronic lower back pain. And it took me probably 2 sessions, probably maybe about 30 minutes each session, just describing what this pathway is like and what that really means for him in his life. And after those 2 sessions, he really understood, wow, I never made I've always heard that, yes, stress can cause pain. We've all heard that, right? That's on the news. That's in popular culture. The zeitgeist right now is that stress equals pain. And the more stress you have, the more pain you have. And a lot of times that's true. But when you can distill it down to, you can deliver the science to someone and then connect how their life or their lifestyle influences their body and how that connects to the science, then people start really connecting the dots. And then they can say, okay, there's actually a physiologic reason for what I'm experiencing. I can see the connection between my body and my brain. And I can see the connection to how what's happening in my life and my lifestyle is impacting how I feel, i.e. the pain in my back. And what's interesting about this particular researcher's study is that there are probably evolutionary reasons why that pathway exists. So if you think back to way back, obviously in time when we were just coming down out of trees and we were fighting and things like that. If you were stabbed in the back with something, let's say an axe, that ignites your fight or flight response. So today we don't have, for the most part, we're not stabbing people in our society, hopefully, but it goes to show you how chronic stress can kind of strum the same neural pathway, if you will. And if you can help people make those connections, connecting the pain science with the pain education, which is what you're delivering, then people really have these aha moments. And then once they understand that, then they can go through the things that Brandy and Dominique are talking about with making changes to their therapy and their lifestyle as well.
No, thank you for sharing, and thank you for the clarification on that distinction. No, that's fascinating. And Dr. Parker, next, so would you feel free to share a story about how this has impacted a patient in your care?
Yes, I'll give you kind of a common patient that I often see. She was a 70-year-old female who had pain for, she couldn't really even remember for sure, but 30, 40 years, no specific incident. Like a lot of the patients, the doctors had tried various things and injections, and she had gone to many different people in the health field with no relief, or any relief that she had had. It was very short term. But I was treating her and giving her some information about pain and how the brain and the thoughts and the emotions all tie into the physical aspect of pain. And one day she came in and she said, I had something really weird happen to me. And I was like, well, what? And she said, I realized I wasn't in any pain last night. And it was almost a scary moment for her. Like it brought on more anxiety to her to not have pain. Then almost pain had become her middle name because it was so ingrained in who she was for the last 30, 40 years. And I asked her, I said, well, there have been some things we've talked about you wanting to get back to. Is there something you want to do right now that you can do in the clinic with me? And she said, yes, I want to touch my toes. I said, what? She said, I want to stand up and touch my toes. She came from a background where she really valued that she was the flexible person in gym class and in sports. And I said, okay, stand up and touch your toes. Well, at first she bent forward and she touched her knees and she just fell back into the chair. She didn't stand up. And I said, well, what's your feedback? She goes, I didn't hurt. I said, okay, keep going. So eventually, after about 5 attempts, she touched her toes. And she just started crying, guys. And I said, what's going on? Share with me. She goes, I never thought I could do that. And she said, I don't understand. I don't hurt. She said, I knew if I touched my toes today, I would hurt more. And that's why I didn't want to do it, but yet I wanted to do it. And so that's the patients that I see over and over again. And fast forward a few weeks, and I asked her, I said, what made the difference to you? What was that game changer for you? And she said, permission to move. She said, I never really knew it was okay for me to move because I knew that if I moved in the wrong way, I would hurt myself more and it'd be permanent. And that's the type of pain that I see in my clinic a lot. And that's the common answer that they give me when I ask them at the end. Because guys, our patients give us really good feedback. And when I'm learning, I like them teaching me. what made a difference? What was it that you heard? What was it that we did? What was your experience that seemed to turn the corner for you? And that's a common answer that I hear is you explained it in a way that made sense to me. I understood my pain for the first time, and I had permission to move in ways that I wanted to.
Tyler, can I comment on something that Brandy said?
Yeah, absolutely, please.
And I'll tie it in with there's a question in the chat thread that I'll kind of tie this in with. Emily had asked, how can one go about repairing a patient's trust within the healthcare system after it's failed at helping them cope with pain? And if you listen to the early part of Brandy's story, where this is a woman who's 75 years old, who's had pain for many decades. She obviously has been to see many different practitioners. She may have even seen prior physical therapists for all we know. And people with chronic pain at times do come into sessions with us with a little bit of trepidation, and that's normal. And we just have to kind of be mindful of that and notice that and realize that that's part of the journey that you're going to go through with the patient. But as far as repairing the trust and the relationship with the patient, or the trust that the patient has with the healthcare system, the beautiful thing about pain education is that in some aspect, you're probably going to set aside some time. It could be 10 minutes, it could be upwards of an hour, depending on what setting that you're working in. And when you set aside that time, there's going to be an aspect where you're teaching and you're also speaking with the patient and you're explaining pain to them in a way that they've never heard before. Most people, when they work their way through the medical system, they're spending maybe 5 or 10 minutes with a practitioner. They're not getting essential pain education that's required to change their outlook and their view on it. So the first thing is they're like, wow, someone's actually sitting down with me for the first time in a nice chunk of time. They're first listening to my story, because that's going to be part of your initial evaluation, right? What happened to you? Not what's wrong with you, but what happened to you. And then once you listen to their story, then you can start to go into the pain education part, which is explaining pain to them. Just those two, right? Those two things right there. What happened to you listening to their story? And then can I share with you how pain works in both the brain and the body is probably the most critical and the first step in repairing that relationship with someone. And what you're doing with that, you're not treating someone. What you're doing is you're empowering someone. You're empowering someone with knowledge. And when they have the knowledge, not only are they empowered to understand what's happening, but then they can decide what treatments they want to move forward with in their pain recovery. So there's some good questions. That question Emily had was really good. And I think it tied in really well to that story that Brandy is saying, because really in that interaction between Brandy and her patient, where she eventually gave that patient permission to move, is empowerment, right? So Brandy educated that patient about pain, and then she empowered her and said, hey, start to move your body just a little bit in ways that feel good to you and are healthy. And then people start to feel better from there.
That was wonderful. Thank you. I don't know if Dr. Tull or Dr. Parker, I don't know if you care to elaborate on that question at all, or.
No, I think listening to their story is a big part of gaining their trust. We're weird in the health field in that we have more time with our patients than most others. So that time that we can sit down and listen to their story, sometimes it amazes me what they're eventually willing to tell us, and the trauma and the abuse and the incidents and all that they didn't realize probably tie into their pain. Because a lot of them will tell you stories from their childhood or their 20s or 30s, and then they'll finish it with, I don't even know why I told you that. So I think when we listen to them, because some people have never told their full story to anyone, and they've stopped talking about their pain with most of their dear friends and family, because no one understands it. So we may be the first healthcare provider that understands their pain and can tell them about their pain and make sense to them. And I think knowledge is power. So once they have that knowledge of their pain, they can grow from that.
Awesome. Yeah, I think Brandy and Joe pretty much stated it perfectly. I think the most important thing is that knowledge. you're a healthcare professional that is essentially letting them know something new about their body. No one has likely spoken to them this way, educated them in this way about pain, and really just validated their experience. Because we're like, yeah, I understand why this is happening, and I'm able to put the pieces together when I'm providing that pain neuroscience education, and I'm listening to them. I'm able to put the pieces together. So I just think it's just providing with that knowledge is what really kind of builds back that trust.
Awesome. Thank you all. And thank you, Emily, for asking the question. That was a very, very great question. Thank you so much. And I see we have a hand raised over here. Maya, please feel free to unmute yourself and ask away.
Hi, everyone. I'm happy to be here. My name is Maya. I'm a student physical therapist assistant from California. My primary experience has been in the pool setting, so lots of fibromyalgia and chronic pain patients. So I've always been fascinated between the psychological aspects of pain and how we can better help patients have a better experience with physical therapy. So my main question is, especially as students, how can we be better equipped to handle those psychological aspects of pain? I know we're not psychologists or psychiatrists, and we're not really learning about it so much in school, other than chronic pain has a lot to do with psychology. That was, the main introduction we had to chronic pain. So if you guys can talk a little bit more about certifications or other experience you've had to make you more of an experts in the chronic pain field, that would be awesome.
Go for it, Joe.
So the first thing is, even if you have never studied pain education, or if you've never studied anything about the psychology of pain, there's a really important piece of data that I want you to really take away from this talk today. And that's that the one thing you do have on your side is the therapeutic relationship. And no matter how many courses you take on all the various topics you're going to take throughout your professional career. And there have been a number of studies on this, especially in the world of psychology, where they compare, let's say, mindfulness to cognitive behavioral therapy. And there are components of treatment that will help someone who is suffering, who is in pain and suffering. And the first is what we talked about before, is trust and empowering people. And then two is a therapeutic relationship. So the reason why I say that is because when I talk to groups like this, new early career practitioners, PTs, PTAs, there's a sense of like, I don't know enough. So the first thing I want you to know is that you know enough right now. You know way more than your patient knows. So have a little bit of confidence in yourself, and obviously our profession too, that we can impact someone. Now, it's naturally that you're going to want to start to delve into courses and certifications and things like that. Disclosure, I do have a company that provides continuing education. It's called the Integrative Pain Science Institute. There are lots of different ways that, lots of different methods that you can learn with regard to psychologically informed care. You can study mindfulness, you can study cognitive behavioral therapy, you can study pain education, you can study acceptance and commitment therapy, you can study trauma-informed approaches, you can study mind-body approaches. All of these really fit under the umbrella of what we're talking about. Before you maybe do some of that, go out onto the internet and look at some of the free resources that are out there, right? There's tons of free resources. I have a podcast. It's called the Healing Pain Podcast. I probably have about 400 episodes, I believe. Again, free. You can scroll through that. You can look at different topics and listen to those. My episodes are between 30 and 60 minutes long, and see what resonates with you. If mindfulness resonates with you, and maybe you have a little bit of experience in mindfulness already, then do that. If it's more, if you're really interested in more of how thoughts impact pain, then maybe you want to go more into cognitive behavioral therapy or acceptance and commitment therapy. There's lots of different ways, and this is again, even the cognitive behavioral aspect of pain is it really runs parallel to pain science or pain education, and all of this is exploding. So you can study this for your entire career. And most of us, me, Brandy, Dominique, we've all studied this our entire career. So just start to, feed yourself a little bit of free information first, get a, kind of wet your whistle for like what this is about, what it entails, and then look into different types of courses and certifications. I find the ones that are taught by PTs are best because they're going to put them in the context of your practice as a physical therapist. And then I'm sure Brandy and Dominique have recommendations as well.
Yeah, I think that just being open, to kind of go about it from a different way, like you as a student, you as a new physical therapist, being open to have those conversations, because I think that we all can agree, like, for one, treating patients in general is intimidating, but when we're dealing with somebody who has maybe a lot of emotional overload, or maybe has a lot of questions, you may be a bit intimidated by it. So I would say, for one, don't shy away from it, because in my course of having students, these are just things that I always hear, like, oh, I don't know if I can really help these people. And just you establishing that therapeutic relationship with them, even if you don't have the words, bending that listening ear can be something that can really, really just allow you all to be on the same page, allow that patient to feel comfortable. And I think that's the first step. Now, in addition, I think Joe mentioned some great resources, and I'm excited to check out his podcast and check out his the products, because I know even before coming here, just knowing his name and the type of things that he's done, and even hearing them days has just been a great learning experience. But I think that from my background, in my residency, I was exposed to a methodology of treatment called psychologically informed physical therapy. So that has been I guess the framework that has guided me when it comes to the inner workings of how to treat those patients. But what I think is even more important than that is having a solid orthopedic physical exam, right? Being able to get to the point to where you can actually disseminate to this being an actual orthopedic nociceptive issue, or this being some type of pain that is more mediated by the brain. So just having a strong algorithmic process, going through red flags, going through yellow flags, trying to diagnose or trying to get to a specific pain type or category. I think those are things that can really help students to be able to feel just a bit more solid about treating these patients.
If I look back and think of myself as a new graduate, not necessarily even knowing what I know now, but just knowing what I knew then, how could I better help serve some of those patients? And I think acknowledging their emotions. Just, what are you feeling right now? What are you going through? I use it all the time in post-op knees. Our first instinct of pain is to run from it. Our second instinct of pain, if we have it, is to curl up in the fetal position, so to say. So sometimes just acknowledging their emotion about being there, because sometimes you can spot them in the lobby. It may be a younger kid who's anxious or crying. It may be the post-op who you can see it written all over their body language. But just acknowledging those feelings and listening to them, and just giving them some very early education. I like the free tools. YouTube's was not a way for me to learn when I was a student, but Adrian Lowell is a wonderful resource. And I think there's some free YouTube videos that he has with some pain education. He's got lots of metaphors, which is great. And the Pain Institute that Joe Tatta has is a good resource if you're looking for something to pay for. But use your free resources first. See what you like. See if it's kind of you and fits into your toolbox or not.
Awesome. Thank you all for that. And thank you, Maya, for asking that question. It was wonderful. I see we have some questions in the chat, so we're going to take a pause real quick. I'm going to pass it over to our nominating committee chair, Tayo, who has some announcements for upcoming APTA events. Tayo? Or information.
Yeah, what's up, everybody? I'll try to be real quick with this, but students definitely pay attention because there's some money involved. So first one's going to be the Catherine Worthingham Fellow CSM Scholarship. So obviously we have our big event in February. It's going to be in San Diego. This is going to be an opportunity for you to hopefully have some money to be able to attend that at a cheaper cost. So there are 6 $750 scholarships. Yes, $750 provided by the fellows. And that opportunity is currently open right now, and applications are due on September 30th. So if you're interested, make sure to apply to that. Second one we have is another scholarship opportunity. We have our minority scholarship as well as our Mary McMillan scholarships. So that opened up at the beginning of September. That's going to run through December 1st for both of those. And in order to be eligible for this one, you have to be in your final year of school, whether that's PT school or PTA school, either one. As long as you're in your last year, you'll be qualified for this opportunity. Last one, again, another award. It's going to be our Outstanding Student Awards. We're going to have one for an SPT, one for an SPTA. Again, money is going to be involved. Applications are due December 1st for this opportunity. So again, those are some awesome opportunities to win some scholarships. So please feel free to apply to those. Lastly, as far as an update, we have our Student Board of Directors election that will be running in November. We're going to be announcing our slate very soon. So keep an eye out for that on all of our social media pages. If you have any questions along those lines, please let us know. Other than that, that is all the announcements we have for tonight.
Thank you, Tyler. And yes, students, a lot of great scholarships available, so please apply. All right, now we have a question from the chat, and this is from Chris. Oops, sorry, I lost my place. Here we go. All right, so what do you feel has been the most influential advancement in pain science since you started that you incorporated into your practice? Dr. Parker, would you like to start us off on this question?
I mean, really the only pain science education I got was the gait pathway. And, it helps to a certain extent, like you begin to understand it, but it doesn't bring in the psychological component. So I think just putting that tool in physical therapist toolbox to be able to use and be able to link that into the, I have low back pain, or my shoulder hurts, or my knee hurts, and nobody can tell me why, and it doesn't make sense. And I want surgery. They tell me I don't need surgery, but I think just understanding the psychological components of it and bringing that into the full exam of what we can do as PTs is very helpful.
Dr. Tatta, would you like to go next?
Sure. I mean, there's so many. The one thing that stands out to me is the one particular psychologically informed tool that I use is a method called acceptance and commitment therapy, which is a mindfulness-based cognitive behavioral approach that has excellent research in helping people with chronic pain. As part of that package, if you will, of techniques that are in ACT, or what's called acceptance and commitment therapy, is what's called values-based living. As physical therapists, we're excellent at creating short-term and long-term goals for patients. Things like increasing range of motion and strength and walking and returning back to function and work and all those pieces of it. We're excellent at that. Values are the undercurrent that helps with the stimulus for behavior change. So people start to work toward those goals. So rather than just saying, well, we're going to increase your knee strength from a 3 out of 5 to a 5 out of 5. It's like, why is it important that you increase your knee strength? And when you start to get into the values-based living reasons why it's important, things like, well, yeah, I have to return back to work because I'm the sole provider for my family, for my wife and kids. Or I have a new grandchild or a new granddaughter that I want to be able to play with and get down on the, in the crib and play with her. Or I'm elderly, I'm 75 and I'm the primary caretaker of my husband who has early dementia. So when you really start to, and again, this goes back to that therapeutic relationship again, and this is why value is so important, is you start to dive into someone's life and really what their life is about and how you can help them connect in a deeper, more meaningful way to their life, and how your therapy and how working with you helps with that. So I would say values-based living is probably the most important intervention I think I've learned in the past 20 years.
Amazing, thank you. Dr. Tull, would you like to finish this one off for us?
Yeah, for sure. So in my short time as a PT, I've been practicing for 4 years, going on 5 years. So the framework, as I said before, the framework that I've been provided when it comes to treating and managing chronic pain is the methodology of psychologically informed physical therapy, which is essentially an approach that is truly biopsychosocial. once you get to the point of categorizing this patient as someone who needs this treatment, there's going to be some form of activity-based treatment, whether you're using graded activity or graded exposure, which may be based upon whether if that patient has fear, you're more likely to use graded exposure. The type of therapy that we typically think of is impairment-based, so that's going to be involved as well. If somebody has back pain, and if there's any type of tissue impairment or some type of strength that needs to be improved, we're going to utilize that. Equipping these individuals with pain coping skills, and whether that is you providing them themselves or using a mental health therapist to kind of help with that as well. And then just giving them some self-management techniques to manage their pain. So that has been my framework. But what I will say, a new piece of knowledge that has really helped for me to tie that together is having a better understanding of the individual's pain type, and treating that specifically. For example, something that I will try to do more is just understanding that if this area is sensitized, right? This person's back pain is really flared up. And we know that the brain is sending these signals that are increased. Can I do something topically in addition to me using this biopsychosocial framework to really desensitize? So this really came from a lecture that Joe Donnelly was putting on, and he was talking about the use of like biofreeze and those type of modalities to really just help to desensitize individuals. So for me, with having that framework, that structured framework of the type of things that I need to have within my therapy, but then also adding in those topical desensitization techniques, and however way that you may decide to do them, has really allowed me to have a very strong approach when it comes to treating these patients.
Great, thank you all. It's very exciting to see where this topic is going, and like the research that's coming out, and to can see the advancements. It's very, very fascinating. We have another question in the chat from Patrick. He said he has a question on how you would recommend we have a conversation with physicians, nurses, PAs, etc., who are not on the same page with pain education. It's a very interesting question. Dr. Tull, would you actually like to start us off on this one?
Yeah, for sure. So this is actually something that I'm extremely passionate about. Something that I've been working on through my company, PhysioNexus, which is an educational-based, cohort-based learning course for new grad physical therapists and physical therapists who are just looking to improve orthopedic skills. I've been putting out a lot of information on pain, like what is pain? And through that series, my hope is to educate the people, but more importantly, educate medical professionals. So I think that we have to be comfortable with having these conversations with physicians. We know and understand that in some instances as physical therapists, we may not garner the same respect as your medical doctor might. But you, as an experienced and educated physical therapist, when you approach and you talk to these other professionals with knowledge, you know what you're talking about, I promise you'll get a different response. Imagine you calling a doctor in a very non-threatening way and explaining to them that, this is what I see in this patient and this is why. I have the research, I have the data, I'm sending you these things, and I'm conversing with you in a way that is educational, but it's also non-threatening. So as we equip ourselves with this knowledge, I think we have to be open to directly educate those other professionals, because like Joe said initially, like we literally have the largest amount of training in this arena in the medical profession. So we have to take the time and the effort to talk to these other professionals.
Awesome, thank you. Dr. Parker, would you like to answer next?
I think just telling them what you know and what some of your experiences are. I really haven't found too many doctors, PAs, or nurse practitioners that have butted up against this, because really they're frustrated with their population. Their hands are up in the air. I don't know what else to do. I've done what I know how. And once you tell them, hey, send them my way, I've got some tools that if they will get on board with this, that this can help them, they're usually pretty open to it. So I think it's almost like a relief button to them that there is somewhere where they can refer these patients that they're kind of hands tied with what to do with them, so to say.
Yes, thank you. And Dr. Tatta, would you like, sorry, finish this one up for us, sorry.
Yeah. So we're really talking about the topic of health literacy, right? How do we make our society as a whole more literate in pain? So if health literacy is an umbrella term under health literacy, there's pain literacy. Pain literacy can be chunked down into 3 areas. So it's pain education for the individual, pain education for healthcare systems, and then pain education for societies. So as you approach pain education and you become more skilled in all the various things that we're talking about, pain education, psychologically informed care, all these cognitive coping skills, you may have to learn how to, one, have the discussion with other practitioners. That'll be delivered in a certain context with certain vocabulary and definitions, if you will. Obviously, for a patient, you're going to simplify that and make it much easier for them to digest. And then when we think of like health promotion and prevention and public health, pain education can be delivered in larger scale products in society, large campaigns, which there have been, not so much in the United States of America, unfortunately, but there have been large scale campaigns in countries like Australia and New Zealand. So the skills that you're learning now as a student physical therapist or physical therapist assistant, of course, you're going to use those pain education skills to improve an individual's pain literacy. But don't forget, there may be opportunities out there where you can educate either a medical group or a medical system, let's say a hospital or a chain of, let's say, orthopedic groups, or maybe you wind up working for a larger company or corporation or a not-for-profit or a government funded organization that is producing pain education for like the larger society, if you will. So just thinking about pain education for the individual, pain education for healthcare systems, and then pain education for society is a good way to start to create your own frameworks around how you might deliver that.
Awesome, thank you all. And thank you, Patrick, for the question. And I think Dr. Tull said it well too. Sometimes it can be intimidating. At least I know it's intimidating for me right now as a new grad to go up to a PA or a surgeon or whoever to talk about anything regarding just any patients. It can be intimidating to make that first call. So I think it's great to have some strategy so we're all on the same page and we all can apply great care to our patients. We have another question from the chat from Lori. If the chronic pain is in fact mainly caused by mental stress, in which ways do you go about explaining this to your patient? Patients may be resistant to that notion. And Dr. Tatta, would you like to start us off on this one?
Yeah, it's a really, really important question. And I'm happy that someone posted that question in the chat thread. Because, you know, when you're new, I remember back when I first started out, like you stumble over your words, you're not really sure how to explain things. And there's, of course, a learning curve with all aspects of practice. That's why it's called practice, right? As you practice and see more patients and tune your skills, you get better at it. I don't like to use the word mental, because there's a stigma attached to that, unfortunately, in our society. So what I tell people is that there are psychological factors that influence pain. So the 2 key words there are psychological factors, instead of saying mental causes or mental issues or mental conditions. Then provide an example. So for example, when I say psychological factors, have you ever noticed how when you're nervous, your pain may get worse? Or have you noticed when you become fearful about, let's say someone has back pain. If you're fearful about bending over and picking up something heavy, your pain may actually get worse. So the 2 factors there that I'm explaining are 1, fear, and 2, anxiety. So there are psychological factors, and the factors have an influence over your pain. So we're going to work on your body, helping you become more mobile and stronger. And we're also going to work on psychological factors that help ease the stress that's associated with pain. So that's kind of how I would explain it in that case.
Great, thank you for sharing. Dr. Parker, would you like to go next?
I often start explaining it by understanding that our nervous system is almost like an alarm system, almost through a metaphor. And basically kind of give them, we have so many nerves and there's so many miles of nerves, and ask them, if you stepped on a nail, would you want to know? Well, of course they say yes, but you kind of walk them through, does that pain go away right away? And they think about it and they say no. And so, I say, well, pain kind of goes away over a day or two and you take care of the nail in your foot. But eventually the pain goes away, right? And ask them, have you ever experienced that? Well, maybe not everybody a nail, but a Lego, a pin, something, most people stepped on something. But then I just kind of explain that the nervous system is an alarm system. And it's always on high alert, and it's always meant to protect us from pain. But to make a long story short, I go into kind of how the alarm system, if you had an alarm at your house and it went off in the middle of the night, how would your neighbors act? And so, they say, well, they'd call and they'd come over and check on me. And I'm like, yeah, but what about the 14th or the 30th time your alarm system went off? And they all give the predicted answer. Well, they're yelling at me, they're ignoring it. And that's how I kind of explain why other parts of their body hurt. And then I kind of go from there, how pain is multifactorial. And I ask them, well, do you think anything else may add to your pain? And so some of them stare at me blank, and I kind of give them a hint. Well, does your body ever hurt when you're sick? And so they can relate to that, or the cold, or the storm that maybe have happened the night before when I see them. But I teach them pain as a multifactorial experience, and that there's receptors in our nervous system that will add to our experience of pain. And then I ask them, have you ever had like a stressed moment in life when you notice your shoulders rising and your traps right here hurt? And they're like, oh yeah. And so that's kind of how I begin to teach them about pain. I don't actually use mental or psychological or any of those words, because most of them have such a stigma. If I just know my patient population, if I use that word, they're probably out the door on the first visit. And it honestly, some of them, it will take, I usually see them about once a week, and it'll take them 2 to 3 visits to kind of really tie in and kind of start using some of the tools that I give them.
Awesome, thank you. Thank you for providing that that explanation. The way you explained it through your story, that's very helpful. Thank you. Dr. Tull, how do you go about explaining this to patients?
Yeah, for sure. So what I think is really important is really separating pain from physical trauma, right? I really try. That is the goal of the conversation, and really to provide them with the explanation of what pain is. And I think that my depth of explanation, depends upon the patient, and the type of individual that they are. Because for some individuals, a lot of heavy pain science education may be a put off, or it may be too many things to think about. We all can think about patients who may have been slightly anxious, and now you provided them with this very technical explanation example, and it may be something else that may be an added stressor. So I think the alarm example is a wonderful one. It's one that I use all the time. I'll tend to use it in a way to help explain to them maybe how this could have started. So imagine that, someone walked up to your door, and they knocked your window out and the alarm went off. We can think about that as being, a typical A to B response. Stimulus, rocking the window, alarm. But now to kind of pair it with maybe their story and maybe how this developed, imagine the next time, the body is like that. The body is going to want to be prepared and protect itself, because that is the purpose of pain. So maybe the next time somebody walks up and pushes on the doorbell, that alarm goes off. And then maybe the next time, when somebody walks by, that alarm goes off. So I like to use that example to let them know that maybe if you've experienced multiple pain experiences, maybe in a short time, or multiple pain experiences that haven't been treated. And a pain experience, the way I explained it, can be physical. It could be something that's psychological, so I try to paint it to them in that way. And I think the way that I really like to tie a bow on that explanation and education is to really showing them with the exam, okay, as I go through and my shoulder, both of my shoulders hurt. I have this leg pain, this burning leg pain in both legs. So I have to go through an examination and let them know, okay, I'm asking these questions. These are things that may be associated with the red flag and bilateral leg pain. And based upon these tests and such, what your doctor tested with your imaging, it doesn't point to that. What I've tested physically, it doesn't point to that. And as I go through my physical examination and I do my special test, if what you're thinking is this weird, sciatica, for example, which is something that, so many people know about and a lot of people will go to first as a pain associated with the legs. When I go through my orthopedic exam, my testing should be negative, so as you put together the education, you make it real for them with examples that they can understand simply. And then you tie it in with what you're actually testing, what you actually find. I think that puts a really nice piece together for the patients to really understand what's actually going on with their bodies.
All right, thank you all, and thank you all for the questions. So we're gonna be heading out into our breakout room soon. Each one of our panelists is gonna be in a room, and then we'll all be broken up evenly amongst them. I just wanna say really quick, thank you to our wonderful group of panelists. These socials or these events would not be possible without you all. I think for sure, I think everyone can say we all learned a lot from your expertise. So thank you all so much for coming out this evening and making the time for us.
Thank you.